Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Today we are exploring very cutting-edge cancer research and learning about a new technique that isn't quite ready to be used on patients yet, but early clinical trials are just now starting, and I think it's pretty amazing. If it's proven safe and effective, it could transform how patients receive radiation. It starts with an exciting question. What if 6 weeks of radiation treatment can be delivered in less than 1 second? 6 weeks versus 1 second. It's called flash radiotherapy, or flash RT, and it delivers ultra-high levels of radiation into a very short burst. There is still a lot to learn, and my guests today are researching flash RT with the goal of one day translating the science into real benefits for patients. Easier said than done, but that is the journey of research. Joining me today is Dr. Ronald Chen, the Chair of Radiation Oncology at the University of Kansas Cancer Center. We welcome him back to our program. When he's not seeing patients, he's also reviewing scientific studies as an editor of multiple scientific journals. He may be out there performing his own research because he's done a great deal of that, and he has authored several books and national guidelines that other doctors are using when treating cancer. Alongside him is Dr. Gregory Gahn. Did I say that right?
Yes.
All right, man, I'm pretty good today. He's a radiation oncologist as well as a cancer researcher here at KU. He's also a PhD. He's the co-director of the, this is a big word, Oligo Metastatic and SBRT program. We're going to come back to that and see how many times I can say it correctly, here at the University of Kansas Medical Center and the health system. And he's helping launch some of the research we're going to be talking about today. Before we jump into flash, let's explain what typical radiation looks like. It typically requires numerous treatment sessions. Patients come day after day for 4 to 7 weeks. Dr. Chen, why does radiation typically work like that?
Well, we know that radiation is a great way to cure many types of cancer, but also it can cause side effects. And historically, when our technology wasn't as good and it wasn't as accurate, in order to reduce side effects and have the treatment be a little bit more gentle on the body, we broke up the radiation dose to small pieces every day in small doses over 4, 5, 6, 7, even 9 weeks is what we would do to get enough dose to the tumor, but be really gentle along the way to minimize side effects. Now, I would have to say, now, as technology has gotten much better and we're much more accurate, we have been able to shorten that treatment by a lot. And so, for example, prostate cancer used to take 9 weeks of everyday treatment. Now we do a lot of prostate cancer in 1 week or 5 sessions because technology has gotten better and we've been able to reduce side effects and be more effective.
So really, you're having to give these very small doses over a long period of time so you don't affect the tissue around it too much. Is that a fair way of saying it?
Yeah, absolutely. When we give small doses, again, the small doses is meant to reduce side effects. What it allows us to do, what it allows the body to do, is to not damage the surrounding organs as much and allow the surrounding organs to sort of heal every day. And if we give bigger doses and the technology wasn't as accurate, we could cause more damage. So historically, we really were very gentle because we had to, because the technology and the machines weren't as accurate as they are today.
So how might flash change that treatment schedule?
Well, as I talked about, treatment for radiation has really gotten shorter over time. Now, there's still many cancers today where radiation takes every day 4, 5, 6 weeks. Flash therapy is this idea that we can give all of that dose all at once, and in fact, maybe over about a second. And so it's really exciting. We'll talk about that and why the biology of that and how it's worked. But the flash therapy, and I do believe is going to come to clinic in the next 5 to 10 years, will deliver all the radiation dose for a cancer in about 1 second in just 1 session.
That would be a remarkable thing. When we say flash, we're not talking about the guy who runs around in a red suit on TV, right? I do like the Flash Gordon.
I don't know what you're talking about.
It's pretty cool. You're just too young. But Dr. Gahn, it's not just about schedule and convenience. Could flash be able to cause less harm and spare tissues from damage, maybe even be more effective?
Yeah, no, that's that's a great question. And a lot of the preclinical work that's actually been done so far seems to suggest that you can actually deliver this, flash radiotherapy. And when you compare it against, conventional or standard radiation treatment, in preclinical models, there's not as much toxicity, as well as the fact that you still keep that, that tumor cancer control rate, which is exciting. So I think this is something that needs to be, taken forward for sure in clinical trials.
It's remarkable to me to think about years. Like my mom died of lung cancer back in 1979, and she had to undergo radiation therapy to help control some of the symptoms, and she ended up with esophageal stricture and damage, and to think about how much better we are just aiming the dose, but she did that over weeks and weeks. To think about just getting it one dose and less tissue damage, that's really pretty remarkable.
Yeah.
So one of the big recent advancements at our cancer center is the Proton Therapy Center. We've talked in this show before about protons and their ability to spare tissues from unnecessary radiation. Dr. Chen, does the flash concept apply only to proton therapy?
Mostly, actually. What we've realized is that in order to deliver flash, which is a really high dose to the tumor, it really requires a machine that has enough power to do that. And what I think research has shown is that regular radiation machines really are not able to deliver that kind of dose to a deep tumor very well. It really requires a proton machine to be able to have that ability to deliver that kind of dose in that kind of fast time. And so flash is mostly going to be a proton concept going forward.
Can every proton therapy machine be adapted, or do you have to have special ones for that?
You have to. So existing proton machines have to be adapted to be able to have flash capabilities, and in order to deliver that kind of a dose that fast, you also have to do it in a controlled fashion. And in fact, actually, our machine here is undergoing that transformation to be able to have flash capabilities. That's going really well, but you do have to adapt a proton machine to be able to have that.
Staying on the cutting edge, I love that. Now, Dr. Gan, you've brought some images explaining proton as well as flash. Tell us what we're looking at.
Yeah.
This is cool stuff. Really, this before the program, I was like, okay, even I get this. I'm just a lung doctor. That's awesome.
Yeah, no. So you have an example here of a pediatric patient who is undergoing radiation treatment, what we call craniospinal irradiation. The target here is to try and target microscopic cancer that could be in the brain as well as in the spinal cord. Now, in this example here, this is using traditional 3D conformal radiotherapy, stuff that we would have used, obviously, 80s, 90s, and into the 2000s. And then over time and everything, we've been able to adapt this using something called intensity modulated radiation therapy. It's a lot of what a lot of academic centers as well as a lot of clinics use in the community nowadays, and again, very similar. You can see that it actually can treat both the brain, the spine to a very good degree.
But tell us what we're looking at. How do I know that it's been treated? What am I supposed to see?
No, great question. So what's here in red and everything like that, corresponds to a dose, to a dose intensity. And so all the stuff here in red is getting the maximum dose.
Okay.
But there is some additional dose, 30, 25, 20 gray, and this is kind of colored here in green here, and you can see that with this dose that's being delivered, you're able to hit your target, but some of that radiation dose does bleed.
Yeah, you can see a lot of bleed in that green. It's in the spinal column, all the soft tissue around it, into your abdomen, into your lungs, because I know that sometimes you do this, we see a lot of lung problems.
We do see some of this too. But the one on the far right, as you can see, this is using proton therapy, and with this, you're able to still target your brain, your spine, but that bleed dose is substantially reduced.
Just not there. You can see all the organs here, they look pretty good.
Yeah, I know, so they're getting a lot less dose, and so because of that, the side effects are a lot less. And so this is actually, in this indication, it's actually great. This is another example of this, using photon here on the left,
which is regular radiation.
Right, which is regular radiation. Again, this is what's available throughout the world and is most common and is still, again, an excellent way of treating cancer patients. But by no means is this inferior, but it has the potential to potentially reduce toxicity. And in this situation here, this is again, de-identified one of my patients getting what we call ipsilateral or one-sided radiation treatment for a tonsil cancer. And you can see that it does a great job of delivering its radiation dose, but there is some of that radiation dose that bleeds over to the opposite side.
Yeah.
Again, my goal is not to target the opposite side, it's to target this. With proton, I can not only treat this side, but I can spare much of the opposite side, and with that reduces toxicity, potentially for the short as well as long term.
So it's really this very narrow beam that gets in there and zaps the area you want to without getting as much of the surrounding, and that's even without flash therapy, right?
Yeah. Now, again, very similar to kind of what you just saw and everything. This is traditional, very standard of care, great photon-based radiation treatment, kind of re-irradiating a specific area of the head and neck where of a patient with head and neck cancer. This is actually that same plan with proton re-irradiation. You can see so much more of this patient is getting a lot less radiation dose, and so because of that, the potential, I mean, obviously there are complications that can still occur, no question, because of the second time you have to go in this specific scenario, but there's so much less of a footprint that you can see here. Now, with this example here, as Dr. Chen had just mentioned, the ability to potentially or to theoretically give all this radiation dose in one shot, as opposed to having to kind of do this over a 6-week period, which is what was done here. This, as you can see from a lot of the advanced modeling done by Dr. Hao Gao and Yu-Ting Lin's, our proton physicist team, as well as others, have demonstrated that you can actually deliver all of that in one treatment. Again, a lot of these things will need to be modeled and then prepared for.
We're so darn early on it; it's hard to show. But I mean,
it's exciting.
It is exciting, and it's still less the tissue, a little bit more than the over 6 weeks proton. But again, that's early in development, and this is already being used in patients.
This is already being used. It's an excellent way of managing.
Why wouldn't everybody want to do this instead of that? Because I would think the rest of your brain would be very happy if we did it like that.
Yeah, no, great question. Because there are other ways of actually potentially delivering a very similar kind of dose. Something called stereotactic body radiotherapy. And again, this is with the advancements of our current technology as well as computer power, we can actually deliver treatments like this to the head and neck using standard photon radiation treatment, in 5 treatments. The problem though is still, some of that toxicity, some of that additional radiation dose that bleeds across. So proton in these re-irradiation cases, I think, is an excellent option that is offered here, and again, not just for head and neck, but for other body sites. And I think it definitely warrants and everything like that patients who are interested to at least come and chat with us.
It is really amazing. Now, has flash been used on human, Jim?
It has in early studies. So there's the FAST-01 trial that was just completed at the University of Cincinnati, and this was looking at 10 patients, really just to palliate painful bone metastases. There's a new trial that's coming out called FAST-02, and this is going to be looking to palliate, again, simple pilot study, 10 patients, to try and treat bone metastases in the chest.
And that sounds so much better as well, just from the standpoint of, again, it's a palliative measure, so you don't want to have to make people come back to get that thing over a lot and try to shorten that course of therapy greatly. So hopefully that's going to turn out great. Now, we know that too much radiation makes you sick. Wouldn't an ultra-high dose of radiation make someone ultra-sick with a bunch of side effects?
So, for sure, I think as Dr. Chen had said before in the past and everything, when our technology was not as good and we were treating very large areas, for sure, trying to fractionate it was obviously makes good sense, but obviously our field sizes were also very large. Now we're able to keep our field sizes pretty small, and in doing so, that limits our footprint. Good for the patient, good as well for cancer control, and with that, the skin reactions that can come, particularly from this recent FAST-01 trial, seems to suggest that at least the acute, or we would say the early stage side effects, seem to be pretty minimal, very tolerable.
I think we had some pictures of some skin reactions. Do we have that up there? I think there we go. All right, so talk to us a little bit about this, guys.
Let me just sort of go through that. So this is from that one clinical trial that's been done using flash on patients with bone metastasis. And again, ultra high dose, ultra fast. And what you actually see is, a lot of times radiation can cause skin irritation, sunburn, that's what people call it. With this trial from this patient, there's really no sunburn, no skin reaction at all. And so we actually now have some patient data to show that delivering in this way using proton therapy is actually quite safe.
Yeah, that's a pretty remarkable story. Now, how does oxygen impact flash radiotherapy? Because we know that oxygen can interact with some of the radiation and cause some challenges.
Yeah, no, great question. It's a very complex question. I think it's one that we're actively studying right now with the KU radiation biology team. And so oxygen itself, obviously, it's necessary. You need to split oxygen, generate these radicals. That's what's used to kill the cancer. And it's very interesting and everything that the flash effect seems to have a certain dependence on oxygen. And again, I don't want to go into all the details. It'll probably bore everybody in the audience and everything. But it's an area where we're actively trying to study, about kind of the tumor itself, which obviously has very low oxygen demands versus like the rest of the body, and how does this impact potential side effects. So again, a lot more on that to come, a lot more on hopefully the toxicity studies that we're going to be studying as well in our preclinical models here.
So can we develop new computer models to improve how we deliver proton flash radiotherapy to patients? Is that part of what you're doing too?
Yeah, so actually there's a lot of work at KU in our department of radiation oncology on this. Designing a radiation plan, there's innumerable possibilities of where you shoot the beam and how you target the tumor and how you avoid organs. Right now it's a lot of art and experience. We have actually a dedicated research team using computer models to see if we can model these plans better in the future. We're probably one of the world-leading research groups in this area, and yep, there's definitely some results there.
Yeah, I'm really excited. So are you going to be able to perfect this and get it right?
We already get it right. We're going to do it even better.
Awesome. That is great news. I think it's going to take a team, and it's not just y'all. Who else is on your team trying to do this research?
Yeah, no, like I said, it takes a village. We have a number of proton-trained, specialists, clinicians, who have this kind of experience. We also have, some great proton physicists who have that capability, that know-how, funded, R1 funded, industry funded, as well as biologists and everything like that. Who also contribute to that. And so with that, I think all of us are kind of trying to tackle this problem in a multidisciplinary fashion. And with that, I think this is kind of one of those things that kind of sets our system, our healthcare system apart, because not only are we able to kind of continue with the current clinical care that we're doing, but we're trying to innovate that next step. Hopefully, in this case, maybe 2 or 3 steps.
That is pretty cool. So how far away from clinical trials are we?
Well, actually, as was discussed, one small clinical trial has already been done to show that flash is actually quite safe with minimal side effects. There's now another small trial that's happening. I think we're going to get into clinical trials probably in a year or 2. Right now, we're doing sort of animal studies and to make sure that our machine is working for that. But we anticipate going to clinical trials relatively soon.
So where and when did this whole flash RT concept start?
I think this was actually something that probably started. They noted it, everything, as far back as the 1950s. But with that, I think it's taken some time.
It's like before I was born, people. That makes it really old.
But yeah, no, over the decades and everything, this is something that's kind of been studied further, and they started to see, it's like, hey, you see this effect and everything, and it's not just a fluke. This is actually something that is reproducible in numerous studies, and so they started looking into this further and further, and this our current iteration and everything as what we're studying in a lot of preclinical models, as well as in that first clinical trial, human clinical trial.
So it does almost sound like science fiction. I do want to point out that Flash Gordon started before the 1950s. I think it was in the 1940s in some different science fiction fantasy journals. Well, maybe not journals. All right, so it's easy to get excited about these possibilities, but scientific research should be careful and deliberate. How do you make sure your excitement and eagerness doesn't get in the way of the careful scientific approach that good research requires?
I think we're very careful. I think flash is a huge leap from how we currently do radiation. And so it takes, we make sure the machine's working and delivering flash in a very controlled way. We treat animals to make sure that that's safe and that there's no side effects and that it's killing the tumor. And then we go into clinical trials very carefully with things that, the example that's given is patients with metastatic disease. And so make sure we treat a part of the body that doesn't get harmed too easily and observe that very carefully. And so, and that's true for every kind of new cancer research. When you have a new cancer drug, that's also how you progress. And hopefully some of those make it through to really impact patients in the future. And FLASH is the same thing.
Guys, this is so cool. I've gone to school today, and I feel like I've just learned something. So this is awesome. So thank you for being on the program with us, and good luck on those clinical trials. Hey, we are here to answer your questions. Send them using the links on your screen: YouTube, Facebook, Twitter, or email the Medical News Network. Now, we're going to move to the COVID count part of this program. So let's talk with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the Health System. Yes, I said that all the way through for the 1,227th time. Doc Hawk, what's the COVID count looking like?
Yeah, no, you've said it a lot for sure.
Yeah.
It's been a while. COVID count right now, 21 active patients in the hospital with COVID. So down a little bit from the last couple weeks. Hopefully we will continue to see a downtrend and keep people out of the hospital.
So Hawk, let's take a look at some of this combined data looking at both flu, RSV, COVID admits, and then I want to segue into some other discussions with you for just a moment. So,
yeah, you can see there we have the number of admissions for RSV, influenza, and COVID there on those colored bars. If you look way over to the far right, this is data from a week ago, but you can see that our numbers have been really fairly stable for the last couple weeks, moving just a little bit slightly as far as influenza admissions. RSV admissions have continued to stay low, and obviously in the green there, the COVID admissions have pretty much so far been somewhat stable as well.
We've had years where we've had 30 or 40 influenza patients in the hospital, so it feels like influenza and COVID, while still different, I think COVID's a little bit worse, but it's kind of come together a little bit, which probably explains a little of the CDC's recommendations last week, or just announcement last week that beginning in April they may be changing some of the infection control guidelines and saying, well, if you get COVID, you can go to work if you feel okay and your fever's down.
Yeah, I think that's a pretty big shift. Some people, it's gotten mixed reviews so far. Again, we have to wait to see exactly what they do say in April. But the CDC has cited not necessarily less of a disease burden on certain people, on individuals, but overall in the community, less of a disease burden now that we continue to have vaccination immunity, also probably some hybrid immunity with people who have been infected and reinfected, but also the antivirals. And they do understand that people do need to go to work to be able to have money, to have a job, so that they can have child care and all that stuff. Child care is another issue. So they've talked about not only the medical issues, but the social issues available with that as well. I think it remains to be seen what the full impact of that will be. Again, it will be hopefully in the warmer months, so there won't be as much circulation of the virus out there. But we'll just have to wait to see. Some people, some experts are not too happy about that. But I think we need to do what's best. It's not always black and white, and certainly, again, it is always okay to wear a mask when you're out and about as well.
Yeah, I think one of the most important things is whether you've had influenza or COVID or any other viral illness, if you're still sneezing and coughing a little bit, wear a mask when you're around other people. And that's not a new recommendation. That's actually been an old recommendation, not as many people have followed. Now, Oregon and California, I think, have kind of already adopted those standards. My understanding is they haven't really seen a marked increase in COVID.
Yeah, I think that's right. Some of the states have kind of done their own thing, made tweaks to some of the isolation guidance. It seems like it hasn't put an increased burden on their health system. Again, we know that certain individuals, certain demographics, especially if you're immunosuppressed, older age, there are still groups that are vitally impacted by COVID on a daily basis. Have a plan for if you do have symptoms, get tested early, get on the antiviral. But overall, in the community, what they have found was that there wasn't really an increased burden of, again, hospitalization and death with these things. So
yeah, it's pretty exciting. Now,
yeah.
we talk about COVID vaccination for just a moment. There's an important new study that's just talked about COVID vaccine being linked to a lower prevalence of long COVID. I think this is really important.
Yeah, and what we had seen really since the beginning and some of the long COVID diagnoses started coming out, people were doing retrospective looks, and they had seen anywhere from 15 to 30% reduction in your chance of getting long COVID. This is a study from Michigan, so it's a distinct population for sure. And what I like about this is they were taking people who had been PCR positive from March 2020 to May of 2022, those people that had infections during that time, so that was before vaccination as well. And they also looked at 30-day and 90-day diagnosis of long COVID because of different definitions. I think the U.S. has a 30-day and the World Health Organization has a 90-day. If you still have symptoms, you're considered long COVID. Nonetheless, what they did find was a significant chance or a significant reduction in your chance of long COVID for those people that were vaccinated. Now, what they had considered as fully vaccinated was people who had received at least 2 of those doses. And then, of course, unvaccinated people had not received any at all. But what they did find was that those vaccinated people did have a significant reduction in their chance of long COVID. So I think that's good news. One more positive effect of the vaccine.
Yeah. This is it's an interesting time as we transition, but I do think it's a little encouraging to me that the numbers we've seen of COVID this winter have not been what we have seen in the past, less than half of last year, and that the numbers for influenza and COVID are not all that different. So I think it's better now than it was. I would still remark though there's still an increased death rate from COVID, especially if you're immunosuppressed, you're older, et cetera. So don't get cocky. Make sure you follow the rules of infection control. They continue to keep you safe wherever you go, even until this moment and every day going forward. And also remember, vaccination is both safe and effective.
Yeah, and what I would say too is there was an early study from Canada that looked at interim vaccine efficacy for both influenza and the updated COVID vaccine for this year. And what they did find was that there was around a 40% vaccine efficacy for hospitalization or needing to go to the hospital with those vaccines. So the vaccines continue to work and reduce your chance of going to the hospital and having severe disease. We are still waiting for the U.S. data on that. But
good. It's good stuff. Okay, we know many of you may have some questions. Let's head to Studio B with Alexis. Alexis, good morning.
Good morning. We have a question from Jean. Jean wants to know, is the main advantage of FLASH the convenience of fewer treatments, and how would it compare to brachytherapy for prostate cancer?
Oh, that's an interesting question. That's actually an informed question.
That's a great question. So, well, brachytherapy is a long, well-established treatment, and we use brachytherapy for prostate cancer, GYN cancers. There's a long track record for that, and oftentimes brachytherapy is one procedure, maybe up to 5 procedures. So FLASH is another way of delivering radiation really fast. We still need a lot of clinical trials to establish its safety and efficacy, so it's not quite there yet. But I think the comparison is reasonable. I think when we make treatments shorter, it makes them more accessible to more people. We treat a lot of patients in our proton program who drive more than 50 miles to get here, and if they have to drive that way for 3, 4, 5, 6 weeks, it's really a toll. But people can usually probably drive here for 1 day for 1 treatment, and so I do think in the future, if FLASH does come along, we can do it in 1 session, we'll have a lot more access of patients to the proton program.
Alexis.
We have a question from Ruth Ellen. Ruth wants to know, will this type of treatment help with glioblastoma brain cancer?
Great question again. Again, as has been mentioned, this is something we're going to have to study in clinical trials. I think, just with any technology and with any treatment, it has that potential promise because there's different biology with how FLASH may potentially work in contrast to, say, more conventional radiation. But again, we're going to have to look at this in clinical trials. So hopefully it will. But again, let's see what the future holds.
And I'll just add to that. I think glioblastoma, there's a few cancers right now, like glioblastoma and maybe pancreatic cancer and metastatic cancer, where we really need to do better. I mean, glioblastoma, our current treatments are not working that well. And those are the conditions where a new technology like FLASH can really offer hope. And I do think that some of the trials in FLASH will probably prioritize those conditions.
I have a question for you, Dr. Gan. Jack writes, what was the word in Dr. Gan's title? Igloo something? Can you repeat your title?
Oligo.
Oh, that's right. We never went back to Oligo Metastasis. That is exactly right. Go ahead. Let's talk about that.
Yeah, no.
Man, I said we were going to. That's on me. I apologize.
No worries. So the word is oligometastasis, and oligometastasis means few metastasis, and really it's kind of a defined state where we think that cancer is either all locally confined versus it's just full-blown metastatic. But I think in reality, one of the thoughts out there is that metastatic cancer, may be the spectrum where you have, non-metastatic, truly metastatic, a very low burden of metastasis, and the ability to potentially still give very curative, treatment with as well as targeting some of these smaller oligometastatic sites. And again, the goal is to try and still trying to achieve cure in a very selected population of patients.
And you may have to hit different targets then with that radiation.
Yeah.
Right,
and we do this routinely right now using something called stereotactic body radiotherapy or hypofractionated radiotherapy, and we have a program here at KU and everything where we are.
You know what? I think you guys have a lot of big words around radiation therapy, and I think the good news is those are all really important and impressive words because they actually mean something, and it means a lot to patients to have that kind of expertise.
We have a comment and then a couple more questions. Cheryl wanted to let you know that she's very grateful. She says, thank you for continuing to discuss COVID, RSV, flu, and of course, new cancer treatments. So that's a grateful viewer, Cheryl.
Betcha.
And we have a question from Bonnie. Bonnie wants to know, how long do you follow research participants to make sure there aren't any late side effects?
Years, actually. So with any current clinical trial and also with new technology types of clinical trials, we follow patients for years and actually very rigorously. So often, initially, we follow them for every few months to see if there's short-term side effects. And I do a lot of prostate cancer. We follow prostate cancer patients for 10, 15 years, not only just for late side effects, we also want to know if we're actually curing patients in the long term without a recurrence. So really a long time.
We have a question from Denise. This is an interesting one. She writes, is it actually important to understand how a treatment works? Because my doctor said no one fully understands how antidepressants work, but they're on the market.
Mm-hmm. That is part of medical science. It is unfortunately true that sometimes we find out, sometimes surreptitiously, that a drug works in a disease. We may not always understand the mechanism, but you'll have a little better handle on this one, I think.
Yeah, no, great question. I think to the the person asking the question, yes, we know that if a treatment works and it can work effectively, this is great, but I think there's that underlying question of biology and how this works, I think is vitally important, because this is how we take that next step. How do we design the next rational trial to actually exploit how we better understand how this disease process works and how our treatment actually works on it. And I think this is, again, the potential of utilizing FLASH with immunotherapy. There's a lot of things that are kind of slowly being unraveled, and I think that there's that potential in everything, that if we can better understand how FLASH may act on the immune system, how it may impact kind of normal tissue, we will know how to better both manage the side effects as well as to maybe pair smarter drugs with it to make it even better.
Yeah, that is just cool stuff. Guys, I am so happy you've been on the program today. This has been a great discussion, and I am grateful to all of our guests and grateful to Hawkeye for being here, who bails me out on infectious disease questions all the time. So would love to hear some final thoughts from you guys before we head out. Dr. Gott.
Very excited and everything about the potential science and the collaborative team that we have here at KU, and just excited to kind of see where we can take FLASH.
Yeah, I'm excited too. All right, Dr. Chen.
Cancer treatment is always changing and getting better. I mean, radiation treatment is not radiation treatment 5 years ago, and every couple of years, radiation is making a big change. And one of the great things about being an NCI designated comprehensive cancer center is that we are pushing the treatment forward to develop something new for patients so that we can cure more patients, have less side effects.
You know, guys, thank you both for being on here so much. You know, I think it's fair to say that people are living longer, they're living better, they're living. And that's different than what happened with my mom back in 1979. Huh.
Yeah. No, really awesome science and medicine, right? Hopefully making people's lives better and continuing them as well. The other thing that we have is those preventive techniques that we can do. And we know that vaccines, as we just talked about, vaccines are effective in helping reduce overall disease burden, but also now, as we've seen with this new data, very helpful in reducing long COVID as well, which we know affects many people on a daily basis. So if we can reduce that burden, that's really good. We know that these vaccines are very effective and very safe as well.
You know, I'm just so thankful to be here today and to be working with such great folks all the time. You know, cancer has affected my family. It's affected me. And to watch the benefits that we're seeing now, we're not quite as good as Dr. McCoy yet. I think he just used an upside-down salt shaker with some funny lights and cured pretty much everything in Star Trek. So I think you guys are still a little challenged. You've still got a ways to go. But to see where you've brought us and see where we're going is a remarkable time. I keep talking about it, the impact of faith, hope, and science when they're brought together, what we can see, what we can do, and what we have to look forward to. We'll see you next week.
She says COVID saved her life. I'm Alexis Del Cid. On the next All Things Heart, we check in with Jackie Adams a year after her heart transplant, how she says getting COVID led to a life-saving diagnosis.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.